Hi, everybody, and welcome to the Mind on Mental Health podcast. My name is Andy Dean. I'm a licensed clinical social worker, and today I'm once again speaking with Dr. Becca Boswell, who's the Director of Psychiatric Services at Penn Medicine Princeton Center for Eating Disorders. Today, Dr. Boswell and I discuss the thoughts and core beliefs that tend to drive eating disorder behaviors. So I hope you enjoy the podcast and find it helpful.
One thing that I've noticed is with eating disorders, maybe even more so than with other mental health conditions, people can have a really hard time relating. Like if I put my caveman brain on, I love food.
Yeah.
It's hard for me, if I take my therapist hat off, to understand how someone could have such an aversion to food, right? And I think you hear this with like family members and friends of people who struggle with eating disorders, like
Right.
just eat, like what's the big deal? Or like, don't you love chicken parm or pizza or whatever it is? And I guess I was curious to hear your perspective on like what those people are missing in terms of what's going on for the person who's struggling with this.
Yeah. So I sometimes use metaphors to help explain that.
I love it.
And, family members can be like, here's pizza. We put it on the table, right? Like everyone loves pizza. It's like everyone's favorite
Right.
Friday night
Of
dinner,
course. Yeah.
right? And like, why couldn't you just eat the piece of pizza? And what the person with the eating disorder sees is like a bowl of spiders, right? Or sees the pizza, thinks it looks amazing, and then hears the eating disorder voice saying, if
Good
you eat
point.
that pizza, everyone's going to think that you're fat and no one's going to love you and you're going to be bad and you'll have to run for 6 miles tomorrow to make up for it.
Right.
Right. And sort of hears that like negative talk from the eating disorder in their brain. And so it's not just about the pizza. It's about what the eating disorder thinks the consequences of the pizza would be. And that, real tension between maybe really wanting to eat pizza and worrying about the consequences of that.
That makes sense. So it's almost like people without an eating disorder, maybe they can empathize a little bit, but they can't totally understand it because they're not, the person with the eating disorder isn't seeing delicious pizza. They're seeing something scary, something that means it's gonna require them to do a lot of work or effort or.
Yeah, I think everyone can think about, right, like fears of social rejection, right?
Sure,
like
of
no
course.
one wants to be told that they're not good or not worthy. And there's many ways that our world tells people that based on their appearances. And I think everyone can understand that a little bit, right?
Yes,
like you
totally.
want to look nice and, seem healthy and bright and have good energy and like have people see that.
Right.
I think that eating disorder voices magnify that so that it's a spotlight on appearance at every moment,
Yes.
right? And so it's like, do I feel brave enough to step out of that spotlight and eat this piece of pizza, or am I
Yeah.
going to be sacrificing too much
Right.
to do that?
The thing that I was thinking about when you were talking about that is just like, it's similar for any kind of phobia, really.
Yeah.
So like if someone has contamination OCD or something, they don't just see a doorknob, right? Like they see potentially disease or germs or
Right.
death even on the doorknob.
Right.
And it's similar for the person with the eating disorder, I think. It's just, you're putting it through a bit of a different lens, but it's pretty much the same idea.
Exactly. And for people with ARFID, right, who don't have that appearance-related concern, it's like you look at the pizza, and I actually hate tomatoes and tomato sauce. Like, I can relate to this. But if I see like a red pie, I'm like, that looks like someone put Play-Doh on like a pizza and then like cheese on top of it. And like, I don't want to eat the Play-Doh. Like, that's not food, right? But I would love a white pizza if it's done the way I like it, right?
Gotcha.
And so that's more of the ARFID mindset of like things stop becoming food. Or start becoming like, if I eat that Play-Doh, I'm going to have a horrible stomach ache and feel really ill.
Yes.
Right? And so there's different fears for different types of eating disorders,
That makes
but
sense.
similar aversion.
Okay. I don't think we talked about ARFID when we were sort of going through the list.
The continuum,
Oh, right,
yeah.
the continuum, thank you. Can you just say a little bit about what that is?
Yeah, so ARFID is our newest category of eating disorders. So it's Avoidant Restrictive Food Intake Disorder. So it still includes that restriction symptom that we talked about, like limiting your food intake. But the reason for it is not fear of weight gain or fear of becoming fat. The reason is for other fears. So it could be, aversion to a particular food or texture. which often overlaps with neurodivergence, but not always. It could be related to like medical or food related trauma. So like allergies or GI conditions or other kinds of upset or like illnesses that become associated with food in like a true kind of phobia conditioning way.
So like if I eat this thing, I'll become nauseous. So then I'm
I'm
just
not going to eat it.
Or could it also be like if I eat at this time of day?
It could be.
Okay.
Yes. And that really overlaps a lot with like medical conditions, GI conditions. And then there's sort of unspecified ARFID that we're still learning more about other reasons that people could be restricting food intake that don't have to do with body image.
Do we see a lot of ARFID on the inpatient unit?
We do, right? Because with ARFID...
So this can get so severe that people require medical care, and it has nothing to do with weight gain or appearance or anything like that.
People can be very interested in gaining weight, like really want to, and still be fearful and restricting their food intake with ARFID.
Okay.
And because of again, we talked about, symptoms as being like the indicators of where medical risk is, the severity of the restriction rather than which type of eating disorder is what lands people on an inpatient unit.
Got it.
And so that could be in the context of anorexia or bulimia or ARFID, depending on how malnourished their bodies are.
I guess I'm curious, no pressure, but I'm going to ask you to teach me how to treat eating disorders in 5 minutes or less.
I got you.
I told you that I do a lot of exposure work and ACT and CBT, but I guess I'm curious, like, what evidence-based treatments do you trust to really treat this stuff, and how do you kind of integrate it all?
So I think that if we look at the research literature on evidence-based treatments for eating disorders, really the standout treatment is cognitive behavioral therapy for eating disorders, which includes, of course, like challenging behaviors as one of the major foundations and the starting point for eating disorders. So that's where we challenge behaviors that impact restriction, right, or might lead to dangerous behaviors. So it's be forward in the beginning, right? Behavior forward.
Oh, got it. Okay, thank you.
And then adds in, right, like the cognitive and emotional pieces later once the behaviors are safe and stabilized. And I think that's really the organizational framework for most levels of care for eating disorders.
That makes sense.
That like, what do we got to do to like shift these behaviors first,
right?
In order to ensure people's medical and psychological safety.
So, if it's be forward. In other words, you're targeting sort of the behaviors first and challenging them. What does that look like in practice usually?
So it looks like a lot of motivational work. And a lot of setting up environmental context to support challenging.
But could you give me examples of like what the behaviors might be that we're challenging?
Yeah, so say someone is having one meal a day and they're really malnourished, and that's like not the appropriate amount of food for them to have. And we're starting to worry about their medical stability. They might be, encouraged by their team to be having 3 meals and 3 snacks, which is the standard and sort of the first behavioral treatment target that we look for.
3 meals, 3 snacks.
3 meals, 3 snacks.
Okay.
Not leaving too much time in between eating episodes for a couple of reasons. One, because it's, good to not get too hungry with eating disorders.
Why?
Sometimes hunger is a trigger for restriction or a trigger for binge eating.
Binge eating, I guess on the surface makes sense to me.
Yeah.
How is hunger a trigger for restriction?
Hunger can be reinforcing to people that are restrictors. It feels like,
I'm
hungry, that feels really good. Maybe I want to stay hungry.
Okay, thanks.
Yeah, so the 3 meals, 3 snacks is sort of one of the foundational first behavioral targets. And so a team might recommend that to someone, and they might say, there's no way I can do that on my own. And so we'd bring in, right, like supports, whether that's meal coaching from the team, meal coaching from their families, or meal coaching from their treatment team to say, like, here's what your meals and snacks are. Here's how to make them nutritionally balanced, right? Like, let's work our way through it.
Okay. Okay, so those are the behavioral, eating more, essentially. Are there other things that might fall under this umbrella?
Sure. So if folks are engaging in compensatory behaviors, right, like that's where it's also a be forward treatment, right? Like an exposure and response prevention to the urge around vomiting or exercising or whatever that is, and practicing tolerating that distress so that the urges lessen. And that also requires a lot of motivational work, as you know from your OCD work, and also requires a lot of environmental support.
Okay. So this is essentially building the muscle.
Building the muscle.
Of sitting with that uncomfortable feeling?
Yeah. And it's not like a one and done kind of thing, right? It
Right.
takes practice and training and time to build strength in those behavioral processes. And then once there's safety and stability in those behaviors, then there's room for understanding, right? Like what are the thinking and emotional patterns that contributed to this in the first place, right? Like what's making it harder for me in these moments?
Right.
And how to challenge, right? Like the structures psychologically that created the behavioral pattern that they've broken out of.
I want to ask you, and I realize we can't spend 3 hours talking about this
Yeah.
one thing, but like that behavioral component, I totally see the connection and like how those things are targets. Could you maybe explain just, or give a couple of examples of how you start, what are some of the cognitions you might challenge and like how you go about setting that stage, I guess?
Yeah, I mean, I think there's some core cognitions within eating disorders. And so there's sort of the surface levels and the core belief levels within CBET.
Okay.
Some of the surface level beliefs are things around body size or shape for folks that have body image concerns, like
Yep.
sort of challenging their beliefs about their appearance and others' appearances.
So how might you do that?
So, for example, people with a lot of body image concerns might say, you know, I'm only going to be likable if I'm thin and appear this way, or that's like the right way to look, or it's bad to be, and unhealthy, right, like to be in a larger body. And so we'd, you know, check the facts on that, or like start to think about, you know, for all the people that you love and care about, do you only love and care about them because they're skinny? Are they skinny? Right? Like, does that actually matter? Right? And like, how do our interpersonal values maybe differ from some of the cultural messages we receive as people in this world? And like, really, if we check the facts on like body size and health, like, does that narrative match the scientific data around well-being, which we know that they don't.
I'm going to ask you a bit more of a detailed question.
Sure.
In traditional CBT, you kind of challenge the thought, right? From an ACT perspective, you just kind of notice that it's there.
Yeah.
Is there research on like, what do you find personally is the most helpful way to sort of approach that? Or if you're going to be directive with a client and tell them, this is what you do when this thought comes up. What would you tell them to do? Would you tell them to directly challenge the thought? Or
Well, I mean, I think that people have different
things that work.
preferences, different ways that things that work. And so I kind of take the like throw everything at it and see what sticks approach, right?
Yeah.
Of like, maybe some people really have a mind that likes to challenge thoughts and sort of like dissect them and like reconsider, right? Like what they believe is true. Some people might not enjoy that method of thinking or not find it particularly helpful. And just the idea of separating from our thoughts, having body image be something that we're culturally conditioned to but not responsible for, right? Let it come and go, being a much easier way to like adjust their thinking, and that's perfectly wonderful too.
Okay. Sorry, I totally interrupted you. You were, I think, going to give me another example of
a core belief.
Core
So
belief.
sort of surface beliefs around bodies are certainly part of it, and then there's core beliefs across psychopathology that come up, right? Worries about being unlovable, worries about being bad, right? Having done something wrong, not feeling worthy, right? Are sort of below all of these other psychological structures that build up to an eating disorder. And so when someone's in a place where they're challenging the behaviors around the eating disorder and challenging the surface cognitions around it, there's a question, right, of like, what is the function of all of these eating disordered thoughts for you and behaviors, and like what is it trying to work around within how you see yourself? And that brings people to a place of really thinking about, right, like what is driving me in these contexts, and how do I find a more healthful way to feel loved and worthy and good?
Oftentimes something I'll say to people when it comes to anxiety or trauma is like, your brain's trying to keep you safe.
Right.
It sounds similar in that respect.
Very similar.
Because they're essentially, the eating disorder is stepping in, trying to make you lovable so that people like you, or
Right.
Or worthy, so that, again, maybe there aren't social consequences or whatever it is. But is that more or less right?
That's more or less right? I think that there's a popular approach in eating disorder treatment, internal family systems, that has a language around this that a lot of our patients find really compelling. I see them as like different languages for different modalities.
Okay.
But the IFS version of talking about core beliefs would be saying that there's sort of an exiled part of you, a part of you that feels vulnerable and like young and needs protection, and the eating disorder stepped in to protect you.
Okay.
Right? But maybe that part of you that is exiled is not so dangerous to be part of you, right? And maybe you can take care of that part of yourself and not need the eating disorder to step in and manage everything for you.
Okay. Thank you. That was good psychoeducation for me.
Yeah.
I don't know anything about IFS.
Thank you all for tuning in to Mind on Mental Health, brought to you by Penn Medicine Princeton House Behavioral Health. Next time, I'll be continuing my conversation with Dr. Boswell as we talk about eating disorder treatment outcomes and how patients can stay motivated in recovery. We'll see you then.